Good morning and good afternoon, everybody. Thank you for joining us for the Center for Global Health's seminar series that examines building effective global health partnerships. This morning, we're joined by Dr. Jennifer Cohn, who has graciously, agreed to speak with us about partnering to link innovation to access is the title of her presentation. But before I turn it over to Jen, I'll read a quick bio, a more formal introduction. Dr. Jennifer Cohn is an infectious disease physician with a focus on improving access to and uptake of effective health products and models of care in low and middle income countries. She serves as the global access leader for Global Antibiotics Research and Development Partnerships, or GARD-P, and is a clinical associate professor of infectious disease and a scholar at the Center for Global Health at the University of Pennsylvania School of Medicine. Before joining GARD-P, Jennifer served as a senior vice president for cardiovascular health at Resolve to Save Lives, was the senior director for innovation at the Elizabeth Glaser Pediatric AIDS Foundation, and the medical coordinator for Doctors Without Borders Access Campaign. Jennifer has served on international advisory groups for TB, HIV, and non-communicable diseases and viral hepatitis. She has published over 80 papers in peer-reviewed medical journals. Jennifer received her MD from the University of Pennsylvania and is board certified by the American Board of Internal Medicine in Internal Medicine and Infectious Disease, and she earned her master's in public health at the Johns Hopkins School of Public Health. And with that, I'll turn it over to Jen.
Great. Thanks so much, Alejo. And very honored to be invited to talk with you guys about my experience creating partnerships and working on projects through partnerships in global health. I think we have a relatively small group today, so I think we can make this informal. I do have a slide set to go through, but maybe I can try and make it a bit more interactive to make it more interesting, and also hear about your thoughts and your experiences so far in partnering in global health. So let me start off by sharing my slides. Let me see how to do that. Here we go. Okay, great. Can you guys see that? Okay, great. Fantastic. All right. So I'm going to start off with talking about a project I did that was a multi-country, multi-stakeholder project that focused on improving early infant diagnosis for HIV among infants, but also thinking through how we can use a technology to improve HIV viral load detection in pregnant women as well. So I'm just going to give a little bit of background, since I know Alejo told me that the audience might be quite diverse. So I'll give a little bit of background about why early infant diagnosis is important for HIV for infants, and why viral load is important for pregnant and breastfeeding women. And then I'll talk a little bit about the project and really focus on kind of some of the partnerships we developed and how they helped us get over the access barriers that we faced. So first off, how diagnosing HIV among infants actually requires infant virologic testing, or IVT. And that's because, unlike in adults, infants actually get their mother's antibodies passed on to them. So in adults, you can actually just test for an HIV antibody. However, in infants, you can't test for the antibody because it might be falsely positive, because they may just be having their mother's antibodies and not actually be infected. So you actually need to look for the virus itself, which requires actually a more complicated type of testing using molecular testing, as opposed to kind of the more pregnancy test-like tests that we use for antibody testing, or COVID-like tests that we use for antibody testing for HIV. So it's really within HIV exposed infants, time is really of the essence. And that's because in infants who actually have acquired HIV, either in utero or peripartum, they have a peak mortality of 8 to 10 weeks. So you have an incredibly limited amount of time to actually make an intervention, get those babies onto antiretroviral therapy and get their viral loads controlled so that they won't die and they have a chance to go on and live a healthy life. The WHO actually recommends, because of this very time-sensitive nature of the testing, that infant virologic testing results come back no later than 4 weeks following the sample collection. And because of this need for rapid detection, the WHO recommends that point of care testing is used. Rather than what traditionally had been used before this project, which is actually centralized laboratory testing. And I'll talk a little bit about what that means in the next slides. Recently, this has also been recommended by the PEPFAR country operational plans, as well as a number of other major donors, PEPFAR being the major bilateral HIV funding mechanism between the US and many countries where HIV is endemic. Now, why is virologic or molecular testing for HIV critical for pregnant and breastfeeding women? So basically, the reason for that is that the chance to pass on HIV to infants, if one is an HIV-infected pregnant woman, is completely dependent on whether or not the viral load is controlled, or what we call suppressed. And modern antiretroviral therapy is very effective at actually suppressing viral load and massively reducing the risk of passing on HIV to one's infant. Now, of course, that's also good for the pregnant woman, since having one's viral load suppressed among HIV-infected individuals is critical to making sure that person can maintain a healthy, active life. Unfortunately, the risk of having a high viral load, a high HIV viral load during pregnancy actually appears to be higher than in age-matched women who are not pregnant. And this may be due to a number of reasons. And people who had previously achieved virologic suppression have a 22% risk of actually becoming viremic, having a higher viral load during pregnancy. So we have to be very cautious about closely monitoring viral load during pregnancy and rapidly responding. Now, again, similar to infant virologic testing, which relied on molecular testing, testing of viral load also relies on molecular testing, and traditionally this is done at a centralized testing laboratory. So you miss that really critical window for both infants and pregnant and breastfeeding women to actually make an intervention, in the case of the infant, saving their life potentially, or making sure that they can lead a healthy life. And in the case of the pregnant woman, making sure the pregnant woman is healthy, but also massively reducing the risk of that pregnant woman that the HIV would be transmitted to the infant. Well, what was the current situation before we started this project that I'll talk about during the presentation? So essentially, before we started the project, both early infant diagnosis as well as virologic testing for pregnant women relied on centralized laboratory testing. And that meant that a specimen needed to be collected at the health facility, then it needed to be transported to a laboratory, often which were only kind of within large provinces, just one of them, or even just at the capital. They needed to sit and batch the numbers of samples, because these types of molecular testing often took like 96 samples at a time. So in order to be cost effective, you wait until you get 96 samples. So you sit there and wait until you can run the test, and that could add time. It needs to be analyzed. Then the result needs to be recorded and transmitted back to the health facility. And that could either be a physical transmission, where the actual paper result was transmitted by by motorcycle or other mechanism back to the health facility. Or it could be done through this thing called an SMS printer, where the test is sent by SMS to the health facility itself. And then finally, you needed to wait until the healthcare provider, the test result, and the caregiver were all in the same room to make a clinical decision. And in general, that time frame was 30 to 90 days. And I'll show in our study, it was actually more on the higher end of that. And so you might miss that really critical window of 8 to 10 weeks to actually make an intervention and save that baby's life. And basically, with centralized laboratory-based testing, infants not only had to wait, about half of those infants never even received results. So about 42% in our study never actually received results. And this means wasted testing reagents, wasted human resources, unnecessary repeat testing. And in infants, that can be painful, loss to follow-up. And then, the critical piece is you're losing patients to follow-up, because if the mom has had to come back time and time again to try and get the result, it has to wait a long time to get it, and then it never comes, you risk losing that infant and that mother to loss to follow-up and reducing trust in the healthcare system, reasonably, because the healthcare system has failed them. And then, of course, high infant mortality among HIV-infected infants who actually don't get that critical antiretroviral therapy that's timely. And what about in pregnant and breastfeeding women? Why is this important in pregnant and breastfeeding women? Well, as I mentioned, time is of the essence here too. So one, just to go back to that trust in the healthcare system, there was a randomized controlled trial in South Africa that looked at POC, or point of care, so immediate results, versus laboratory-based viral load testing, again, like that 30 to 90 days at least, among people living with HIV on antiretroviral therapy. And what they found is that actually just the use of point of care testing increased retention at 12 months after initiation on ART. 89.7% in the point of care testing group versus 75.9% in the laboratory-based group were retained in care at 12 months. So we can see this actually point of care testing, getting that immediate result, may increase retention in care, according to this RCT. And maybe that mechanism is because people trust the healthcare system and they feel like they're getting cared for. And what about, why this is important? So again, that time is of the essence. So what we see here is another study that looked at basically two different antiretroviral drugs, a newer drug, dolutegravir or DTG, versus efavirenz or EFV, when starting antiretroviral therapy late in pregnancy. And what it showed is that even if we start dolutegravir, represented by the red bars, late in pregnancy, a significant number, nearly 80% across most of these subgroups, actually attain virologic suppression, thus reducing the risk of mortality and morbidity, both for mom as well as transmission for baby. So we have the opportunity, even if we get this viral load fairly late, we have the opportunity, if we can act on it, to actually reduce poor outcomes for both mom and baby. So what could we do to improve mothers' care within the health system? So this is, again, the kind of the typical thing of what happens. The HIV mom presents for prenatal care, a viral load is drawn, 50 to 70 days delay because we're doing it at the centralized laboratory, and then the result is delivered. Ideally, there's still time to make a positive change in their antiretroviral therapy, or if they are viremic. But can we short circuit this? Can we basically make a point of care decision by introducing point of care during this particularly critical time period in a person's life? So that's really the rationale for why we engaged in this project to introduce point of care molecular testing for HIV initially for infants, but also potentially down the line for HIV infected women as well, pregnant women as well. So I'm going to talk a little bit about the project and what the opportunity was, and again, kind of how we partnered to make this project a success. So again, when we started this project, pretty much the only thing that was happening was conventional laboratory-based virologic testing for either infants or pregnant women. And we saw an opportunity because these two different point of care technologies had come onto the market. They were automated, so they were kind of like plug and play. They were quick. You got your results between 52 and 92 minutes, depending on which technology you chose. They were battery powered, so you could have the power go out, and actually, so they were adapted to low and middle income country contexts, and they were highly accurate. But the challenge that we faced is that they were more expensive per test, but not necessarily per result, which I'll talk about in just a moment. There were issues with breakdown and service maintenance. There were supply chain issues. These products at first were not quality assured. They were not registered in countries, and they were not supported by any of the healthcare systems. We didn't know if, for instance, the healthcare staff at the facilities could actually operate these machines accurately. And there was not necessarily a cost-effective, scalable model, and no donor nor country necessarily had this in their guidelines. WHO at the time didn't even have it in their guidelines. So we said, we need to figure out how to address all these barriers and do some studies to see if this is actually a beneficial, cost-effective technology. So maybe we can just pause here and just talk a little bit about who would be our partners. So maybe I can open this up, since I think we still, can't actually see you guys since I've got this on presenter mode. But, it'd be great to hear kind of who do you think would be your partners if you were to engage in a project like this? Who would you want to partner with? I think we may only have one other person on the line. So is it Ahmed? Or Alejo? Oh, I see Glenn Galton actually is also on the line. Hi, Glenn, please go ahead. If you're speaking, you're on mute, but I see your hand is raised.
Okay. Hey, John.
Hi, Glenn. How are you?
Well, I would do it with either the ministry centrally and or others locally as representatives of the ministry, maybe the local district people or local, and whoever is going to feed in to the network from the primary site that you're working.
Absolutely. That was our number one partner, is actually the ministry. So that was really critical. And so basically we saw them as the sustainability partner. They were our major partner. If you're coming at this from kind of a nonprofit view, from a more commercial view, they were our client. But the Ministry of Health was the key partner there. Oh, I think we may have lost our only participant besides Glenn, of course.
Yeah, it's weird because we can't see Alejo. We can't see anybody else on the screen here, so I have no idea who's on.
Me neither. Let's see. Aman Kaur. Okay. Alejo, are there other folks actually attending?
Yes, we do have a few other folks here.
Oh, okay, great. Sorry, the only person I saw was Glenn and yourself, so I didn't know if we were just talking amongst ourselves, which was fine. But sounds good. So yeah, please post any suggestions or comments in the chat. So as I go through, or if you have questions, I'm not sure if there's an ability to come online, but at least post in the chat so we can.
Jen, can you hear me?
Yeah, go ahead, Glenn.
Yeah. So I had been jotting down questions as you were talking earlier, because obviously sustainability is just a key feature to all of these, these types, all global projects. So it's good to hear, but not unexpectedly, you're working with ministry folks. But how did you strike the balance between when you discussed this with them and everybody agreed on the project about what you were doing and what they were doing, and how did you map out a sustainability plan, both for the conduct of the work, but also, about the equipment when it breaks down and when you got to replace it, and, all the stuff, because it's pretty common, as I don't need to tell you, we got US institutions, or maybe, more wealthy institutions, go into places, swoop in, have the resources, get everything started, show everybody how to do it. And, then we depart at some level and things maybe continue for a while, but obviously it's common for things to tail off over time,
Absolutely. I think these are critical questions, and that's a really good segue into some of the slides I'll show in just a minute. But that was one of our major concerns. And actually, when we went to both PEPFAR and Global Fund initially with that was one of their major concerns. They kept bringing up these graveyards of Cepheid machines, other point of care products that they'd used before. And so this was one of the really critical things we wanted to demonstrate, how not to do that, both through long-term service agreements, as well as through the implementation model we used. So we went to the ministry and we kind of asked exactly that. Is this of interest? What do you think is a problem? Is this of interest? What are the barriers for you? And what do we need to generate in terms of evidence, affordability, et cetera, to make this something that could actually fit? And we also went to these leading national, regional, and global experts, including, as I mentioned, PEPFAR and Global Fund, and of course the WHO, and we asked them, what is the evidence you would need to make this a recommended product? Because in some ways, the donors and countries often follow WHO guidance, especially for things like HIV. Let's see, here. So we also went to funding partners and said, would you fund this? And at first the answer was absolutely not. And we said, oh, but then we went to governments and they said, this is critical. We don't have the money for it, but we are, in some cases, they were willing to go to development banks to help fundraise because they thought this was a mistake, actually, that PEPFAR and Global Fund were not supporting these technologies because they saw the pretty horrific outcomes that were happening to HIV exposed infants. We went to civil society and affected populations and said, is this a problem for you? What evidence do you need? And how can we work together to get the funding, to get the guidelines, et cetera? So we went to both communities, but we also went to other kind of very influential civil societies like OAFLA, which is the Organization of African First Ladies Against HIV/AIDS. We went to industry and commercial partners. So we went to the diagnostic companies, Abbott, at that time it was Alair, they got sold to Abbott, and Cepheid. And we said, what are your problems? What are your interests? Where are your pinch points, and how can we bring the cost down? And how can we address the service problem that's been flagged, particularly by PEPFAR and Global Fund? And we went to the distributors as well and said, these products have short shelf lives. How can we get them to the point of care before they expire? And then we went to research groups to say, here's all the data that all our partners need. How can we partner to actually get them the results that they need? And then finally, we went to other implementing partners just to keep them abreast of what we were doing, because they might be the ones helping to support capacity building and implementation down the road if PEPFAR and Global Fund actually supported that. And we looked at kind of within each partners, what was their motivation? What was their interest, and do we have a shared agenda, or is there separate agendas? And particularly for an MOH, if the MOH had said this is not of interest, then maybe that was not where we wanted. We wouldn't want to kind of push an agenda on them because they were our primary stakeholder, they're our primary partner. Looking at the capabilities, what does each partner bring to the goals of the project, and then what is the needs? How can each partner strengthen the other? So then, we talked about a little bit about what are some of the barriers and opportunities to introduce point of care early infant diagnosis. So we didn't, we talked about the cost, we talked about that there was no infrastructure there, that they were short shelf life, that there was this concern about breakdown and kind of these graveyards of products, and that the funders were not there actually at all. They were not willing to fund this. And there was kind of two different agendas between what the ministries were interested in and what the donors were interested in. So we said, let's think about how can we address some of these barriers. So I'll start off with kind of the model of care. So we said, how can we integrate this work into the existing system? We don't want to create a parallel system. And we also want to make sure that this product is introduced in a very efficient way into the current system. So we first determined what is our EID access goal. And we worked on this, just as Glenn suggested, with the Ministry of Health. And we identified a few key outcomes that we needed to track and develop data for. Then we assessed what is the current early infant diagnosis landscape. And we actually went in thinking, this will be a product for like far-flung territories. Maybe in cities you keep the existing centralized system. What we actually found is that the turnaround time and the results delivery and the outcomes were pretty much as bad for cities as they were for like the rural areas. So we ended up suggesting that this is actually something that needs to go everywhere. But we did it first, say, what's the distance to currently available testing? What's the turnaround? We wanted to try and differentiate as much as we could where we could keep the existing system or strengthen the existing system and where we needed to introduce a fundamentally new technology, and try to map out where placement of point of care would be most efficient. So we didn't necessarily think we could place point of care virologic testing at every single health center. So how can we map the demand for this type of testing to where we would place the product and the need for this type of testing? And then, so basically we said, let's use point of care if the conventional system isn't meeting their goals. If there is a point of care site, like there's a TB Cepheid, how can we actually integrate HIV virologic testing, molecular testing, into the existing point of care platform? And then finally, where are the gaps where we actually needed to place a new platform? And so what we did is we developed several different models of care, and we really worked with the Ministry of Health, diagnostic implementing partners, including USAID, who does a lot on diagnostic mapping and optimization, and folks who work on supply chain and sample transport. And we said, all right, in high volume areas, we can maybe have a standalone site where like moms who go to that site will get their infants tested. But really, for the most part, we relied on this hub and spoke model, where there would be a hub that actually had a machine there, but then there would be smaller spokes that sent samples there, but the samples had to be transported and the results come back, basically sample transport within an hour and result return within 3 days. And so we made sure we were able to do that in order to use this hub and spoke network. And what that meant was a 6.6-fold increase in access to point of care testing, timely point of care, near point of care testing, without increasing the number of machines that we were planning to place or leverage through integration at already existing machines. So that was useful because it addressed some of PEPFAR and Global Fund's concerns, but also reduced the cost, because the cost of the platform was a significant cost, at least when we first started. So then we also wanted to make sure we were integrating into places where there was existing infrastructure and training, or the ability to absorb that infrastructure and training. So we did a pre-implementation site assessment, and when possible, we actually used HR, and we closely relied on the Ministry of Health and basically other implementing partners and healthcare workers to determine what should the patient flow be, who should be trained, and who should be task shifted. And just to say, there was a lot of skepticism about the ability to task shift to nurses for this work. But that was critical because at these decentralized systems, it was just nurses there. So we had to demonstrate, we had to build the data necessary to show that nurses could actually do it. And then we used very pragmatic trainings, short facility-based trainings that people didn't have to leave their facility for and come to a hotel and like miss work, et cetera, et cetera. So we demonstrated that even the training model could be minimally disruptive. And then we supplemented that with on-site site monitoring, and we integrated that into the already existing quarterly site monitoring that usually the Ministry of Health and implementing partners were already running. And so what we did is we demonstrated that task shifting from lab techs to nurses was possible. And this is essentially, we used a couple different indicators to demonstrate that. One was return of timely results. They were equal on that. The other was errors. So were the nurses able to actually prepare the sample, put in the machine, read it according to what both the internal quality control as well as external quality control. And these are errors between overall, and then you can't see it well, the techs are in the orange and the nurses are in the blue. And yeah, it kind of started high. There was pretty high percent errors when they first got it, but that's normal. You have to learn how to use a new technology. But then rapidly it came down and stayed low, and about the same between nurses and lab techs. So we demonstrated to a sufficient degree that they were able to do, nurses were able to take this on. But then we also recognized the cost of these products was not going to be sustainable. We really needed to bring the cost down. So we've demonstrated that this, is feasible from a health infrastructure and kind of integration standpoint. But what about cost? So we needed to bring the cost down. And we needed to make sure that we were also leveraging the partners. So we worked with the Ministry of Health and also funders to estimate demand. And we used that demand or that forecast to say, hey, diagnostic company, here's a carrot. What are you going to give us for this? We also worked with civil society so that they said, here's a stick, and I'm going to beat you with it until you give us a lower price. And we also, of course, worked with industry to bring all of that carrot and stick together. And what we ended up is a significant reduction in both the platform price and the cartridge price. And then to Glenn's initial point, we also introduced this very innovative, sorry about that, this very innovative model of care, which was a bundled model of care that I'll talk about in just a minute. So we reduced prices for both the platform, the cartridge, and the service and maintenance agreement. But then we also worked with Abbott to actually make an all-in cost. So the manufacturer said, we'll give you a $20 per cartridge test price, but that will include the placement of the platform, the service and maintenance and sample transport and cartridge transport. So this was very good. And this also incentivized Abbott to make sure that their platforms were actually running, because that's the only way they got the money, is by making sure that cartridges could be run on their platforms. And this was really welcomed, particularly by Global Fund. But then we said, all right, but what's the bottom line? The bottom line is patients and lives saved. So what we did is we made a 9-country pragmatic study. We also did a cluster randomized RCT, which showed very similar results, but I'll show the larger number from this 9-patient study, where we looked at before and after implementation of point of care. So conventional EID, before the lab-based EID versus the point of care EID. We did a subset of our total sites to do the pre-intervention assessment, 102 sites, over 3,000 tests, and then the post-intervention, over 1,500 sites and 126,000 tests. And we went from the median turnaround time from blood sample collection to results returned to caregiver from 50 days to 0 days, significant. The percentage of results received by the caregiver within the WHO recommended 30 days went from 19%, terrible, with conventional EID to 96.9% with point of care. We went from the number of HIV infants started on ART within 60 days of sample collection from 41% to 92%, and the median turnaround time from sample collection to ART initiation among HIV-infected infants from 50 days to 0 days. So we really significantly improved ART initiation and the chance for a healthy life among these infants. And we really partnered closely again with the Ministry of Health, which were our co-investigators and co-PIs on this study, as well as research universities locally. But then we said, let's bring that all together. Cost effectiveness. Is this affordable? So we said, all right, it's true that the cost of a lab-based test is about $10, and the cartridges for point of care range from $14.90 to $25. Those were the initial prices when we started. They've come down a bit. But the cost per test result returned is kind of what matters, because if a result isn't returned, that's wasted cartridge, wasted money, wasted everything. And so we looked at basically the point of care testing, the cost per result returned in 30 days, the WHO recommended 30 days. And as you can see, this is the conventional is $131 per test result returned versus much cheaper for all of the point of care scenarios we chose. And even if you expand that to 3 months, by which time many infants will be either lost to care or lost their lives, it still works pretty well. It's still fairly cost effective when we use this very crude technology. And again, we partnered very closely with the research universities, Ministry of Health. And then I'll show on the next slide, we did some modeling with Harvard to look at cost effectiveness in terms of years of life saved. And so they used a well-documented model, Harvard used a well-documented model to actually basically demonstrate that point of care early infant diagnosis as compared to the lab-based conventional improved survival by 6.8% just in the first 3 months of life, and was cost effective as compared to this conventional or lab-based EID. And the incremental cost effectiveness ratio of point of care versus conventional early infant diagnosis, lab-based early infant diagnosis per year of life saved was $630 US. And that is very cost effective by most measures. And when you compare that to other incremental cost effectiveness ratios based on the same model of an intervention versus kind of standard of care, you can see point of care early infant diagnosis is down here as compared to other widely accepted interventions that are currently supported by PEPFAR and countries. So this goes to not only cost effectiveness, but basically ability or willingness to pay. And then we also wanted to make sure that, some of our other key stakeholders, healthcare workers, wanted this, even after they actually experienced it. And so we did some qualitative research to document that the thoughts on point of care versus conventional, and it was extremely accepted. And we had high rates of suggestion to scale this up nationally. So as I mentioned, we also looked more broadly at how can we make sure this technology, the point of care early infant diagnosis platforms that we placed and that we catalyzed through additional funding through PEPFAR and the Global Fund actually can benefit others. So we've now begun to work on, should viral load be used for other extremely vulnerable groups, children, patients with advanced HIV disease, pregnant women, and then confirmatory viral load after an initial detectable viral load. And then just a couple last slides. So just wanted to say that we worked a lot with civil society as well as other advocacy groups like OAFLA to change policy through evidence-informed advocacy. And this is, for instance, the First Lady of Cote d'Ivoire at one of the events. We worked with Health Gap, GNP Plus, the the African Society for Laboratory Medicine, UNICEF, a bunch of other groups, basically to really mount a large advocacy campaign. And what we came out with is that all 9 countries that we worked in now have recommendations, and they've approved the point of care technologies. WHO has moved to a strong recommendation, but based on our cluster randomized trial, and PEPFAR recommends point of care testing strongly in its technical guidance, and Global Fund is also paying for point of care testing and has recommended it in some of its technical guidance. So this was, again, something that we worked across a lot of different partners to create this program, to do all of the nitty-gritty kind of implementation steps, and then critically to come out with an outcome that hopefully will improve the lives of HIV exposed infants and their moms and families and communities in a sustainable way. So that's pretty much what I wanted to talk about. And I just wanted to show a couple pictures, and just to say, like, this project was obviously incredibly dependent on the interest and passion of the healthcare workers. So this was a group of healthcare workers in Cameroon, not in Cameroon, in Cote d'Ivoire, who we worked with at one of the health facilities, one of the many health facilities that really was, critical to the success of this project. And then this is my team with all the leaders from the various different countries and our headquarters team. So thank you. And I'd love to hear questions, comments, thoughts, etc.
Yeah. Thank you very much, Jen. Thank you. That was an excellent presentation. It enlightened me more to what you were doing and really expanded upon the complexities that a partnership like yours has, and all of the details and thought process that is required. And I was really impressed that you really hit, like, oh yeah, let me ask Jen about this, and bam, you had already addressed that issue. So as Jen mentioned, if there are any questions, please feel free to post them in the chat, raise your hand.
I see one question in the chat already.
Okay, yeah, from Ahmed. So did you model a conservative risk criteria to avoid negative testing, thus wasting the limited kits?
So the project that I spoke about was on HIV exposed infants. So we had documented that the moms had HIV, and that the recommendation was to provide a virologic test for them. So they essentially would be getting a test almost, regardless, whether the recommendation from WHO is to get a test, not to use risk stratification for testing. Now, given that the number of lost tests and kind of wasted funding for conventional EID, we really thought that it didn't make sense to make some sort of risk screening about whether or not a child would get an early infant diagnosis test, because it was more cost effective actually to give them a point of care test. We did, as I mentioned, try to figure out, are there certain facilities or contexts in which it made more sense to maintain the conventional testing. And I didn't show this, but we presented a poster at I can't remember where we presented it, IAS, I think, that showed that actually the turnaround times for I chose cities where there actually was a conventional laboratory site in that city versus sites that were greater than 80 kilometers away from a conventional lab, and they were equally terrible in terms of the turnaround time, as well as the percent of infants who actually received a result. So we had really thought we would only need to put this into the rural, more far-flung sites, but in the end, we ended up recommending that this is a test for everyone. The other thing that we did with the Harvard group, at basically the request of PEPFAR, was that we looked specifically at countries where there'd been a lot of conventional lab strengthening. And we did another model where we did a cost effectiveness of lab strengthening versus point of care, and point of care did still come out to be cost effective.
Thank you. Are there any other questions or comments for Dr. Cohn?
Yeah, it's Glenn again. My usual long list of questions.
Awesome.
So how did you track this then over time to actually, you hoped it was sustainable? How often do you check in with what's still happening? And as sort of the corollary to that, what are the differences between the different countries in their ability to, you know, as you've tracked it? And the third part of that one, sorry, is why do you think there are, because I'm sure there are some differences between countries. So what worked in terms of sustainability? And if it hasn't all been sustainable, what happened? And why do you think that would be?
No, those are really great questions. So we have, along with Chai, been tracking because actually these machines are hooked up to kind of metadata that demonstrates just, you know, are they being utilized, etc. And about 83% of platforms are still being utilized on a regular basis according to historic utilization. So most of the machines that we at least kind of have data for have actually been able to be maintained. Now, there are a few problems. So in particular in Zimbabwe, with the kind of major economic crisis and major healthcare worker strikes that happened in late 2019, we saw major disruptions, but I think that those disruptions happened across the healthcare system and were not unique to this testing project. The other thing I would say is that unfortunately, Abbott has not necessarily decided to continue its investment in this line.
That was going to be my next question.
Yeah.
So we've seen this a lot in some of the cancer work that we do in Central Africa. Rwanda is the prime example. The companies will sometimes, I mean, no offense, but they'll come in and they'll either offer actually, you know, free or reduced pricing, but they have a window because, you know, for lack of a more delicate way of saying it, in the long haul, they want a profit margin.
Yeah. So at this point, they're maintaining the prices we negotiated. The issue is we had discussed with them, and I can't share the exact prices, we had discussed with them much more interesting discounts, and they had thought about investing in both TB and Hep C development, which would reduce basically the total cost of ownership because you'd have many more types of tests being run on a given machine. And as far as I know, they've abandoned those developments. So whereas we have the current products, in some ways, this is going to be a time-limited, ideally will be a time-limited product, because hopefully we'll get other molecular platforms that will outperform and outprice them because they've abandoned their development essentially.
And you've already got, obviously, you've already got the hub and spoke model in place. So
Yeah.
that can be applied. Sort of just a selfish question about Lesotho, because we've actually been planning a project in Lesotho, got obviously disrupted by the pandemic. How was the ministry there to work with?
Really, really great. In fact, they hosted one of our first kind of kickoffs. They may have been the first country to actually, I think our first test was run in Lesotho, but they've been fantastic. EGPATH, where I did this project, has a very strong relationship with the Lesotho Ministry of Health.
Yeah, we met them when we were there, and they've been very good with us. Again, we haven't initiated this project because of the pandemic. My last question, and I don't mean to put you too much on the spot with this one. So PEPFAR and all of these large funding agencies are great because they provide, you know, wonderful sources of funds for these activities. And over time, they've become much more, what's the right word, you know, results oriented, but which is good. Although sometimes, you know, burdensome to the locals, but it didn't always start that way, to be blunt. And one of the things that I'm always concerned about when we initiate conversations, particularly, you know, in sub-Saharan Africa with partners, is that for many, there's just an assumption that there's this golden pot of money sitting in Philadelphia or at PEPFAR, wherever it is. And so I just want your thoughts on these broad national mechanisms or multinational mechanisms of funding. And are there better ways to kind of structure these things so that, we don't cultivate this sort of, belief that, because we can contribute, but ultimately, obviously, they have to, sustain.
Yeah.
I don't know, maybe that was too open-ended.
No. I think this is a great.
Maybe than a question.
And Glenn, are you saying that in terms of the sustainability needs to move from PEPFAR away from that sort of centralized funding, or that the sustainability?
As you know, we do a lot of work in Botswana, and the challenge in Botswana, particularly of late, is as the funds are reduced because of where the country is situated. Actually, the areas that overlap with the areas you've been talking about are actually deteriorating somewhat in terms of HIV status, et cetera, HIV and TB status and infection control. And because, they were just frankly totally dependent on PEPFAR funds.
Yeah, I mean, I definitely don't have the answer, but I think this is a key question. I think with regards to products, we are really at risk of kind of a cliff, and in more even with Global Fund, because they've really accelerated their transition than PEPFAR, and also because they cover more product areas than PEPFAR does. But we are at a major cliff because both PEPFAR and Global Fund have served as market consolidators, market organizers, and they have strict quality assurance standards. They're able to leverage massive volumes, and we're about to fall off a cliff where all of that is going to go away. And, Global Fund put up this like Wombo platform to try and, for countries who graduated or transitioned, whatever the appropriate term is that the Global Fund is using now, to try and, procure products through this like Amazon-like platform that could still leverage volumes. It's been a failure as far as everyone I've talked to has said. So I don't think we have a great answer even for products, let alone for models of care. Now, I do think PEPFAR has moved into this localization stance, which I think is painful, especially for the international NGOs, but is kind of the way I think that needs to happen in order for some sort of transition to happen. And then, one thing that I thought was really interesting in this project is that Cote d'Ivoire and Cameroon straight off the bat said, we're not interested in only getting this funded by PEPFAR. This is a major priority. We want to go to zero transmissions. And they actually funded, I can't remember what percentage, but a decent percentage of this project when it was transitioned from the Islamic Development Bank. So they actually, so I mean, I think there's pros and cons to loans and that sort of development as well. But that is, they made a deliberate choice to say we want independence from PEPFAR and Global Fund on this particular thing. But I think it's scary from a market perspective what we're facing.
Yeah, it kind of reminds me of a comment I heard from a medical student who was doing a clinical, maybe end of second year or early third year medical student. So they maybe had a couple of clinical rotations at that point, but nothing substantive. And they were somewhere and somebody had an MI and they leapt in and quote unquote saved the person. And we got very upset with them because we said, you're not qualified to do this. And they had not been trained in, life support services or anything at that point. And you're not qualified and you shouldn't have done it. And they're basically, well, what was I supposed to do? Just let the patient die? So that's kind of the dilemma that we face in this one too. You have the initial fund source, you can help. You've done, you've shown through your project a beautiful example of that's an incredible, incredible transition. But then I always worry about
what happens
the back
next
end and what's going to happen because we can't be there forever. And I think we've seen examples. We've seen examples where the ministries will say, "Yes, we're completely committed, and yes, as your funds go out, there'll be this transition plan," and then it just doesn't happen. And it's just yeah, it's very difficult. And then you kind of,
Yeah,
I don't know. I don't know.
I agree.
I'm just
I
venting my
agree.
frustrations.
No, there's not a good answer, and it is quite, it's an existential question in many ways. I think, yes, we're getting prices down, things are becoming more efficient, we're lowering the barriers, but there's still not a great complete bridge to get us there.
Well, I guess that's the reason for, as I think most of us always advise people when they're starting projects, pick your partners wisely, make sure that they're the ones asking, just as you did, for the need, that at least, ideally they're people that you've worked with before. There obviously are transitions in government officials, but, sometimes at the ministry levels, there's the middle layer of management that remains constant regardless of the political layers, and if you develop relationships with people, I mean, that's kind of the way I sort of think about it, but it's just hard. It's hard because I think sometimes you just got to walk away from certain places because you just don't have confidence, even though they need it.
Yeah, no, that's absolutely true. And I think, it's about picking the partners. And, in some cases, sometimes the Ministry of Health is not the right partner. Luckily, because I was working through EGPAF at that time, they had developed really great relationships in all of these countries. But, when I was with MSF, it wasn't all, MSF is very independent. But when we transitioned, we didn't always transition our sites to the ministry. Sometimes it was a different partner, and it really had to depend.
Yeah. And we've seen that with partners too, actually, in Lesotho, for example, we saw it there.
Yeah.
Okay. Well, thanks. I didn't mean to dominate the questions.
No, this was really great, and great to hear kind of your some of what's going on in your projects and some of your concerns and thoughts too.
Yeah, thank you guys very much for that. Just a quick update on time. We have about 4 minutes left before 10 o'clock. If there are any, last minute questions, feel free to put them in the chat. If not, Jen, is that okay if we can share some contact information?
Of course.
With the individuals who joined us today.
Absolutely.
But yeah, if there's no other questions, I'll let everybody go. And again, thank you very much, Jen, for speaking with us. And
No, thank you for having me. Really enjoyed it.
Yep, thank you.
Thanks, Glenn. Thanks, everyone.
Bye-bye.
Bye, everyone.